Good morning to everyone. I would like to start by thanking the organizers for inviting me to talk about muscle MRI for the diagnosis and follow-up of Pompe disease. My name is Jordi Diaz-Manera and I am Professor of Neuromuscular Diseases here at the John Walton Muscular Dystrophy Research Center in Newcastle. I have just arrived from Barcelona, in Spain, where I spent more than 15 years following up patients with inherited and acquired muscle disorders. I have a special interest in Pompe disease. I have done several studies in this disease, including some imaging studies implementing muscle MRI, for example, but also some clinician descriptions. I participated in guidelines for treating patients, and I have also keen interest in basic research in Pompe disease. But today I'm going to talk about muscle MRI. So I'm sure that you know all these. Pompe disease is a rare hereditary disorder with recessive pattern of inheritance. The prevalence is around 1 case per every 40,000 inhabitants, so it's a rare disease. And it's produced by mutations in the GSD2 gene. This gene codifies a protein that is called alpha-glucosidase, which is a lysosomal enzyme responsible for the breakdown of glycogen inside lysosomes in the cells. So in normal conditions, what alpha-glucosidase is going to do is to metabolize the pass of glycogen to glucose. This glucose is going to go out of the lysosome to the cytoplasm, where it enters the glycolysis process to obtain energy for the cells. When you have a mutation in the GSD2 gene, what happens is that glycogen cannot be converted into glucose, and the cell still requires energy, so the cells keep sending glycogen to the lysosomes to be metabolized. The problem is that after a while, these lysosomes will become fully of glycogen, and we will have a lot of lysosome with glycogen inside in the cells. So eventually we will have muscle fibers, plenty of glycogen, as you can see here in this photo, where you can see these pale pink areas, which is the glycogen inside the muscle fibers. In the long term, lysosomes will break and release all the content to the cytoplasms, and the enzymes that are inside the lysosomes are going to start destroying muscle fibers, which is going to be injured and after a while death. So physiopathology of the disease starts with a healthy muscle. We have accumulation of glycogen. This will produce injury in the muscle fibers that will die, and we will have necrosis and loss of muscle fibers that are going to be replaced by fat and fibrous tissue. So fat and fibrous tissue does not have any kind of contractile property, and this will link to muscle weakness and permanent disability. We can see all these very good and very easily with a microscope, but with MRI what we are going to try to do is to identify all these different steps. So we have a lot of experience in analyzing and identifying fat in the muscles. We can do it using a sequence that is called G1, and that G1 identifies fat replacement easily in the muscle. So you can see here two different pictures. The first one is from a healthy muscle, and you can see first on your left, and you can see here, for example, thigh, the slice of the thigh, and you can see the skin and a lot of fat underneath the skin, and this is normal because we have a lot of subcutaneous fat tissue. And then the muscles that are in this gray or brown color, and then in the center of the muscles you can see the femur bone. If you take a look to the picture that's called Pompe disease, you can see there is a clear increase in the amount of fat in the subcutaneous area, but most importantly, there is an increase in the amount of fat inside the muscles. What is happening there is that this patient is losing muscle fibers, and these muscle fibers are becoming replaced by fat. And fat has always this white appearance in G1 weighted imaging. So I'm going to present today some of the results of a study that we did in Barcelona some years ago. That was what we call the Barcelona Natural History Study in Pompe disease. In this study we included 36 patients with late onset Pompe disease. 23 of them were symptomatic and treated with myosin. 3 patients were symptomatic at the start of the treatment, but they did not receive treatment at that moment. They started treatment later on. And 10 patients were pre-symptomatic. So we follow up this cohort for 4 years with clinical and functional data every year, spirometry, quality of life scales, and a muscle MRI. And this was performed in Barcelona in Hospital Sant Pau once per year. This study was supported by the Spanish Association of Patients with Glycogenosis, by Sanofi Enzyme, and was only possible thanks to a collaboration with Philips. And I want to show you this photo. It's a very special photo for me. These are 3 of the patients that participated in the study, and they came that day, and they were visited by our physios in São Paulo. And this was a study that we did in close association with the Association of Patients in Spain. So the first thing that we did was to analyze MRIs at baseline. We quantify the amount of fat in these muscles using a score that is called the Mercury score. This is a semi-quantitative score, observer-dependent, but a very easy and reliable one. Here what you do is you quantify the amount of fat in the muscles. 0 is no fat at all. 1 is when fat replaces less than 30% of the muscle. 2 is when fat replaces between 30 and 60% of the muscle. 3 is when it's more than 60%, and 4 is when there is a complete replacement of the muscle by fat. And what we did is we analyzed all muscles of the body in patients with Pompe, and we generated these heat maps. Here what we are doing is to order the muscles from the more affected to the less affected. So you can see the Mercury score in these squares. Every square is one muscle and one patient. So you can see that the lighter the square is, the less affected it is. The darker the square is, the more replaced by fat it is. And then the computer, what it's doing here, is to organize the muscles and the patients from the most affected to the less affected. Here, in the files, in the columns, you can see the muscles, and from the right to the left, you can see that the more affected are on the right, the less affected are on the left. In the lines, you can see the patients. The more affected are at the bottom, the less affected are at the top. And this is something that the computer is going to do, ordering the patients and muscles independently, so unsupervised. And what we also ask the computer is to draw a dendrogram, and the dendrogram tries to cluster the muscles that are more affected and the muscles that are less affected. And here what we identified is that there were some muscles that were more affected, and these muscles were the tongue muscle, the subscapularis muscle, the latissimus dorsi muscle here, close to the thorax, and the serratus anterior in some patients, and also the paraspinal and abdominal muscles. When we move to the lower limbs, we also identify a group of muscles that were more affected than the others, and these muscles were the psoas, the glutei muscle here, the posterior muscles of the thighs, and later on in the progression of the disease, the quadriceps. And interestingly, we also identify some muscles that were not affected, and these muscles were the muscles of the legs. So what I have just described here is the pattern of muscle replacement on muscle MRI of patients with late onset Pompe disease. This is useful for diagnosis. So we in medicine, when we see a patient with a lingual muscle weakness, we sometimes perform a muscle MRI. If we see a muscle MRI like this one, we can think in Pompe. And I think that this pattern is pretty characteristic of the disease, not completely specific, but help us to distinguish Pompe from other disorders. So I think that muscle MRI can be useful for the diagnosis of patients. Interestingly, we also analyze the muscle MRI in patients that were presymptomatic. These patients were represented in the first column, with this orange color. And you can see that there are some squares that are not completely pale. So this means that some of the muscles were affected. When we analyze these muscles, we observed that the two muscles that were more commonly affected were the paraspinal and abdominal muscles. That, as you can see here, there was a close correlation between muscle involvement and the age of the patient. So the younger the patients were, the more normal the muscles were. For example, here in these 11 years old or 15 years old guys, muscles, paraspinal muscle were completely normal. when patients get older, for example, this lady that was 26, you can already see some fat here. And after that, after 39 or 51, we observe a clear involvement of the paraspinal and also the abdominal muscles in these patients that were theoretically pre-symptomatic, so no symptom at all. Here, we also analyze the adductor major muscle. And again, we observe that this muscle was also replaced by fat in many, in theory, pre-symptomatic patients. And there was again a correlation between the age and the degree of involvement. So the second lesson that we have learned is that muscle MRI is also useful because it can identify muscles that are replaced by fat already, even in pre-symptomatic patients, and can be useful to measure, to identify patients that are transitioning from pre-symptomatic to become symptomatic. So first learning points, muscle MRI using T1 imaging identifies a pattern of fatty replacement that is useful for the diagnosis. So the second question that we ask ourselves is there a correlation between findings on clinical examination and findings on MRI? And this started when we start looking at different patients and different typical clinical symptoms. For example, here, this sign here is what we call a partial atrophy of the biceps. This is typical from some muscular dystrophies. When we look at the MRI, there was a partial atrophy of the biceps, as you can see here. This is the humerus bone, this is the biceps, the depth part and the superficial part, and only the superficial part was affected. Here we have a patient with a Pompe disease with a scapula winging. When we take a look to the MRI, we observe that the serratus anterior muscle was gone, was completely replaced by fat, and this is causing the scapula winging. And this is a patient with inflammatory myopathy that is called inclusion body myositis. These patients typically have weakness of the finger flexor. And when we analyze the forearm, there was a clear involvement of the anterior part of the forearm where the finger flexors are. So there were some clear correlation between fat replacement in muscle MRI and clinical signs. So we also performed the MRC scale, so we analyzed muscle strength in patients with Pompe. And we observe again that there were a group of muscles that were more affected than the others, and these were the muscles that were responsible of the hip extension and flexion and the trunk extension and flexion. As you can see, these muscles were affected in almost all patients. When we take a look to the MRI, the muscles responsible of these movements were affected. So, for example, hip extension, this depends on the gluteal muscle. Hip flexion, this depends on psoas. Trunk extension, this depends on paraspinal muscles. Trunk flexion, this depends on abdominal muscles. So the muscles that were weaker were those that were more replaced by fat on the MRI. But we also try to correlate the amount of fat in MRI with other common functional tests that we perform and that are used in clinical trials, like for example muscle strength measure using handheld myometry, the 6 minutes walking test, the time to walk 10 meters, the time to up and go test, the time to climb or go down 4 steps, and some more complex scales like MFM20 or the activities of daily living. And we observed that there was a statistically significant correlation between the amount of fat and the results of this test with a good correlation coefficient. So in general, the higher the amount of fat in the muscles, the worse the results of the muscle function test. So we have learned that fat replacement on MRI is a good biomarker that correlates with muscle function. And then it's important also because it can tell a lot about the physical situation of the patient. And then we decided to use muscle MRI to follow up patients over time. And this means to quantify the changes in the amount of fat, as you can see here in these glasses of water, the changes in the amount of fat that there was in a muscle over 1 year, 2 years, 3, 5, 10 years period of time. So we want to follow our patients prospectively using MRI. We try to do this using the Mercury score. And then we quantify the amount of fat in these muscles, the vastus muscles, between baseline and year 1. The mercury was the same, 2%, because the amount of fat was between 30 and 60%. So there was no difference. And then we realized that mercury score, T1, was not enough powerful to identify changes over a short period of time, because this disease is a very slow progressive disorder. So we need something more powerful, able to identify just mild changes in the amount of fat. And we decided to use Dixon. Dixon, it's an imaging sequence that separates the image in two different ones. One is water and the other one is fat. And then what you can do is to draw regions of interest in your muscles, and you will obtain the muscle area and the exact amount of fat from 0 to 100. This allows you to draw different regions of interest in all muscles of the thighs, but you can also obtain what we call the mean thighs fat fraction, which is a mean measure of the amount of fat in all muscles of the thigh. So with this, what we did was to calculate again the amount of fat in the muscles by drawing our region of interest. We observed that at baseline you had 49% and at year 1 we have 51.2%, and this means an increase in fat fraction of 2.2% in this patient in 1 year. So we decided to follow up our cohort of patients for these 3 years using Dixon, and the first analysis came at the end of year 1. And here, what we observe is that when we compared all the results that we obtained, the results of the muscle function test, the results of the muscle strength, the 6-minute walking test, the time to walk 10 meters, the spirometry, we did not observe significant differences between baseline and year 1. So muscle function was exactly the same in our cohort between baseline and year 1. But we did observe a significant increase in the amount of fat in the muscles of the thighs that was statistically significant, and this increase was plus 1.7% in our cohort of patients, as you can see here. So muscle MRI was able to identify changes in muscles before these changes had an impact in muscle function. We then analyzed all the results, so our patients followed up for 4 years, and the results observed that there was a progressive increase in the amount of fat, as you can see here in this table. Red columns are patients treated, green colors are patients pre-symptomatic. We observed that the increase was stable, more or less 2% per year, and that was statistically significant in all muscles of the thighs in patients that were symptomatic and treated. And we observed that there was a huge variability from one patient to the other. So here in this graph that is called B, you can see in red columns all patients that were treated. And you can see, for example, the first patient that had an increase of 13% in the amount of fat in the thighs, while another patient had just an increase of 1% after 4 years of follow-up. A huge variability. And again, we also analyzed patients that were pre-symptomatic, and we split them into groups, older than 25 and younger than 25. And you can see that the amount of increase in fat fraction was also higher in patients that were older than in patients that were teenagers. So we decided to study if there were factors that could be related with these changes and differences from one patient to the other. And what we observe, and this is what we're going to show you here, is that there were some clinical factors that we were able to identify. We observed, for example, that having an earlier start of the disease, requiring myosin earlier, which is associated in general with a more severe form of the disease, was associated to a severe increase in fat fraction after 4 years of follow-up. The same with the HSS start ventilation. Patients starting ventilation earlier were associated with a more severe and quickly progressive disease. The baseline situation was also very important, so patients that were able to walk longer distance or required less time to climb 4 steps or had higher muscle strength were patients that had a lower degree of progression. And very interestingly, we also observed that the amount of fat at baseline was an independent risk factor. So those patients that had more fat in the muscle were those that progressed quicker. Going back to this, I would like to show you this patient. This is a patient that was followed the MRI at baseline, and this is the MRI at year 3. And you can clearly see that there is a change in the amount of fat in their muscles that is clearly increasing despite being treated with myosin. And importantly, after 3 years, we were able to detect changes in the muscle function test. So we remember that after 1 year we were not able to identify any change in muscle function test, but now that we have been following patients for a longer period of time, we start identifying changes in muscle strength. So this means that fat replacement progresses over the years and can be detected with Dixon, and that early onset of symptoms is associated with a quicker progression of the disease. So I would like to show you this case. This is a patient that we see in Barcelona, in the Barcelona study that I have presented. We started seeing this guy when he was 8 years old. At that moment, he was referred to us because of hypercyclemia, has no muscle weakness at all, with normal life. And I remember that the first visit was completely normal. We performed a muscle MRI that was normal, and we followed him for 4 years. And during all that period of time, he was doing fine. We repeated the MRI 4 times, as with all the patients in the study, and we didn't detect fat at all. But 4 years after, when we finished the study, I remember that his dad called me and told me, I think that you need to see my son again because he has developed some scoliosis and then he has some problems running and playing football. And okay, I said, okay, then bring it to me to Barcelona, and we repeat the clinical examination, and we observed mild psoas and glute muscle weakness, cervical flexor weakness, and scoliosis. And I remember that at that moment I said, okay, now we are going to identify fat in the muscles on the MRI, and MRI was completely normal. So that moment was really important for me because I realized that in Pompe disease there are some steps before we have fat. Remember that I mentioned that we have a healthy muscle, then we have a lot of accumulation of glycogen, then we have muscle fiber injury, and then we have fat. And if we just take a look to the fat, what we are analyzing is the last step. So the last step of the progression, but we are missing all this. And patients can start developing weakness when they are accumulating a lot of glycogen inside the muscle fibers because the muscle fiber cannot contract, or when they have a lot of injury. But I am missing this with the MRI if I just apply T1. So there are different ways of analyzing this. For example, if I want to start a muscle fiber necrosis, I can use a sequence that is called STIR, or a sequence that is called water T2. If I want to study the accumulation of glycogen, I could in theory use a sequence that is called carbon spectroscopy that quantify the amount of glycogen in the muscles. So here I want to show you some results. T2 is a sequence that allows to identify acute necrosis of muscle fibers, so acute damage. This is a patient that have the impact of the light and on one of the sides, and here there is the MRI, and you can see here that one of the muscles is really bright, and this is because there is impact in the muscle, an acute injury, and T2 is showing these changes. There is just one study done in Pompe with T2. In this study, the group followed up patients with Pompe disease for a period of time with T2 and with Dixon. And they observed that when patients had normal muscle T2 at baseline and were treated, after 1 year there was not an increase in fat. And those that were not treated, muscles with normal T2 had a mild increase in fat. When they compared this to patients' muscles that had high levels of T2, so muscles that were showing some degree of muscle injury, they observed that both in treated and untreated conditions, the amount of fat increased clearly. So muscle T2 was showing an acute necrosis in these muscles. And then there are different options to identify glycogen using MRI. One of them had been tested in patients with Pompe in just one study many years ago that is called carbon spectroscopy. Here what they do is just to do this study in the muscles, in a region of the muscle, and identify different peaks that are products that have a lot of carbon. And this small peak here is the glycogen. This has been used in a preclinical study done in rats that were treated with gene therapy and demonstrated that was useful to identify changes in the amount of glycogen in the muscles of the rat. Before and after treatment was clearly a decrease in the amount of glycogen. There are other ways of measuring glycogen in Pompe, what is called the glycosest and what is called the glyconoe, but none of them have been used to study patients with Pompe. So we have learned that active damage and glycogen content can be identified with new sequence on MRI. So today I would like to present a study that we are going to start now in Newcastle. We would like to use muscle MRI to detect glycogen in skeletal muscles of patients with adult onset Pompe patients. That would be very useful because this way we could identify the amount of glycogen, follow up this glycogen in patients that are presymptomatic in order to see if they are accumulating more and more glycogen, and this can lead to muscle weakness. Identify if this glycogen is a good predictor of progression of the disease, and also follow up response to treatment, for example, with all these new treatments that are arriving. So we hypothesize that carbon spectroscopy can quantify skeletal muscle glycogen content in patients with late onset Pompe disease. We are especially interested in patients that are presymptomatic or these patients that are early symptomatic, so patients that are starting with some symptoms and have started or not ERT in the last year. We will concomitantly use T2 to analyze if there is an acute damage and Dixon to analyze if there is replacement by fat. So the idea is that we are going to follow up a cohort of 10 patients and 10 controls. We will perform the carbon spectroscopy, the T2 and the 3-point Dixon here in Newcastle. We will perform a series of function tests just to analyze if there is a correlation between the amount of glycogen and the results of the test, and we will take some blood samples for biomarkers study. And if we see difference between late onset Pompe disease patients and controls, we will perform a GR1 visit just in patients with Pompe, where we will repeat the studies. So the team here in Newcastle is composed by these members. So it's me and Dr. Marianela Schiava, the medical team. The physio team, we have Amy Mayhew and Meredith James, that are two physios with a lot of experience in assessing patients with different muscular diseases. The MRI team is Pete Thirlwall, Ian Wilson, and Fiona Smith here in the MR Center in Newcastle. Pete is an expert in glycogen measurement with MRI. We have Anna Irving, which is our clinical trial coordinator, and Dan Cox, who is the responsible at the biobank. And I would like to invite you to participate in this study. So if you are interested in knowing more about this study, please don't hesitate and send me an email to jordi.diaz@newcastle.ac.uk. And this is a nice photo because this is the photo of the last conference that we organized with the help of the Patients Association, and we invited some international well-known speakers, like for example Barry Vine here, Benedict Schosa here, for example Dr. Van den Rood from the Netherlands, and Dr. Lina Raven from United States. And here you can see patients with Pompe in this picture, and here I am. So if you are interested in knowing what the Patients Association in Spain are doing, here you have their webpage. Thank you very much for your invitation. I hope that we will keep in contact in the future.